多。Okay, so let's start with some body fluid specimen. So the first specimen is a peritoneal washing specimen. This type of specimen is usually obtained during the surgery. And for this particular patient, she is a 56-year-old female with clinical impression of ovarian cancer. So she is a postmenopause female with ovarian cancer, and this is the peritoneal washing specimen that clinician obtained during the surgery. So on low power, you can appreciate that they are many cells, so hypercellularity, and additionally, you can see a lot of cells are in these large cohesive cluster. At this power, you can already appreciate that there are some like a round small material as a core in this cluster. So when we go on higher power, so these are likely psammoma body. Okay, so you can see particularly like this one is a concentric psammomatous like a calcification. So this is very typical for advanced stage ovarian cancer, particularly for high-grade serous carcinoma. So you can see psammoma body over here, right? So this suggests that the tumor already like involve the peritoneum. So the clinician will also perform like direct smear from the diaphragm. So as you can see here, we also see some like high-grade adenocarcinoma cells in the diaphragm smear. So this is the advanced stage high-grade serous carcinoma, and this is very typical that we see commonly in our practice. The next specimen, this is a fine needle aspiration. This is from pancreas. So this is US guided aspiration. This specimen is a little bit difficult, but we do see some very high-grade cell. Okay, so the difficult part is over here. This seems to be quite well differentiated. However, we do see some mucin, but the glandular differentiation is actually not normal in the pancreas. So in the pancreas, usually we won't see these type of mucinous differentiated cells. So these are well differentiated mucinous cells with mucin secretion. So in this situation, you will think about, could it be a well differentiated mucinous like a carcinoma, or can it be a IPMM? However, in adjacent, we already see these high-grade cells. So these are diagnostic for adenocarcinoma. So in this scenario, these can represent IPMM with an associated invasive adenocarcinoma component. Okay, so I would say these well-differentiated cell class are really not normal because of these mucinous differentiation, particularly the mucin seems to have oranginophilic staining, which is corresponding to more like gastric type of mucin. So this is not normal in the pancreas. But because of the presence of these high-grade cells, we can confidently call these adenocarcinoma. But this might suggest it arises from the background of IPMM. So our diagnosis is positive adenocarcinoma. So the next specimen is a pleural effusion specimen. The patient had actually ovarian cancer. So she is not a patient of lung cancer. So in this specimen, we see poorly differentiated high-grade cells, mostly in single cell, some with loose cohesion. So these are already go beyond the diaphragm to the pleural cavity. So this is compatible with the involvement of ovarian cancer with poor differentiation. So the next specimen, also from the pleural effusion, this patient does has lung cancer history. So he had a history of lung adenocarcinoma. The specimen is not very well preserved, as you can tell. And from the smearing, the cells are like distorted, but you can still appreciate that these cells are really, really ugly and with a really irregular chromatin pattern, pleomorphism, gigantic nucleoli. So these are positive for adenocarcinoma and is compatible with recurrence of the lung cancer. So we have a lot of lung cancer cases because this is the most common cancer nowadays in Taiwan, and we treat a lot of these type of patients. So these again another patient with pleural effusion, and these are lung adenocarcinoma recurrence. And one more, another different patient. So for the recurrence of disease, sometimes you can see the cell can still forming the glands. In this specimen, the cells are just very, very loosely cohesive and very poorly differentiated. So the patient also had a history of lung adenocarcinoma, but in this case, it seems to be like very, very poorly differentiated. So this is positive for adenocarcinoma, poorly differentiated. I just want to show the cell block preparation of the typical lung cancer. It looks like this. So you will see small but tight cluster of glandular cells. It is common that you can see a peripheral like a cleft, which is suggests that this is an artificial cleft, but when it present, it highly suggests that this cluster is metastatic adenocarcinoma. So this is the typical morphology in the cell block preparation. So with this specimen, we can perform TTF1 for confirmation if this is the new patient. And we can also perform molecular testing on this type of specimen for either driver mutation or drug-resistant mutations such as EGFR T790M. So this cell block preparation is suitable for molecular testing because we see a lot of cancer cells over here. And I want to show a quite unusual case. So So this is also a pleura effusion from a 72-year-old female. Male. And he has been diagnosed with small cell lung cancer. We have multiple pleura effusion specimen with small cell lung cancer diagnosis. In this particular specimen, we see in the background there are a lot of inflammatory cells. There are some cell in cluster with more epithelial morphology. The nucleus is enlarged. However, it doesn't look like small cell lung cancer at all. So this is kind of strange. So we know that in the background it's a heavy inflammation, so they might cause some reactive type of changes of mesothelial cells. However, the cells are quite atypical, and some are actually in cluster, which is not common for the reactive mesothelial cell. So it's kind of strange because small cell carcinoma rarely transdifferentiate into a non-small cell carcinoma. So with the understanding of the clinical history, we really need to do some further evaluation on these specimens. So we won't call these carcinoma right away because the clinical scenario is very unusual. So we do have cell block. So in the cell block, I just want to show the cell block and compare with the previous case, the cell block that we see. Indeed, for these specimen, there are some really big cluster, some atypical cells with bubbly cytoplasm, but again, this doesn't look like small cell, right? If it is carcinoma, it is non-small cell, likely adenocarcinoma. So we really need to evaluate that if these are truly metastatic non-small cell carcinoma, or this is just highly reactive mesothelial cell. So we would do TTF1, we would do MOC31 as epithelial marker, and we would do mesothelial marker as well. So we would check for these typical cell what's happening, because it is very unusual to have small cell transdifferentiated into non-small cell. So the patient can either has originally mixed small cell and non-small cell carcinoma, but in the pleura effusion initially present with metastatic small cell carcinoma, but after the treatment, after the regimen for small cell carcinoma, the non-small cell carcinoma come out. Okay, so this is kind of complicated, and we will need to further evaluate the specimen. The other situation is, I don't think we missed the specimen from the other patient, but yeah, this is the other possibility that we need to think about. The next specimen is an ascites specimen. The patient had the past history of gastric cancer. He has two different specimens. The first specimen, this is very paucicellular. We don't see a lot of cells in this specimen. However, we do identify these highly atypical cells with very big nucleus. The normal size of the nucleus is usually like the size of the arrow, but this is very big, and with high NC ratio eccentric nuclear. So this is compatible with metastatic adenocarcinoma. And again, here we see another cluster. This is very three-dimensional, so you need to focus up and down to see through. Again, you see the eccentric nucleus, bubbly cytoplasm with pleomorphism, as well as prominent nucleolus. So this is compatible with gastric cancer with abdominal cavity involvement. So the next specimen is a CSF specimen. This is the most cellular CSF specimen that I ever see. The patient had a history of lung cancer. So in this specimen, we see in the background, which is highly necrotic, suggests there is a metastatic tumor with necrosis and seems to be ruptured and with connection into the leptomeningeal spaces. And we still can identify some well-preserved glandular cells with vesicular chromatin prominent nucleolus. So this is adenocarcinoma cluster. So we see adeno and we see marked necrotic background. So this is positive for adenocarcinoma involvement, but this is just way too cellular. So I think the patient won't last for long. Yeah. So then let's move to some fine needle aspiration. This is again a pancreas specimen. So in the EUS aspiration, it's very common that we can see intestinal mucosal contamination, which presented as a very uniform honeycombing arrangement, a very flat, large sheet. And if you take a look of the periphery, the cytoplasm doesn't show oranginophilic intracytoplasmic mucin. So if you see the oranginophilic mucin, that is not normal, which means the glandular cell already has underwent some dysplasia. Okay, so this is a normal contamination of mucosa. So in this specimen, compared to these normal mucosa, we can see these are very tight three-dimensional cluster and with more hyperchromatic nucleus. It is a little bit difficult to see through if it is very three-dimensional, but if you take a look at the single cell at the periphery, you see high NC ratio, enlarged nucleus, and nucleolus, and hyperchromasia. So these are adenocarcinoma cells. So in this specimen, the cancer cell is not so many, but we can see this is a very good contrast. Sometimes I think the cytology specimen is more easy to make diagnosis for pancreas cancer, particularly if the biopsy demonstrate prominent desmoplasia and with only like a crash or very tortured gland, sometimes very difficult. But in the cytology, you can appreciate these are normal cell, and you have the good contrast, and these are malignant cell, and these are adenocarcinoma. So it's very easy to make diagnosis. The most difficult diagnosis, challenging diagnosis for the pancreas EUS aspiration is when we see only very scant, well-differentiated glandular cells, which is kind of challenging. So in that situation, you would really need the context of the, it would be really helpful if you will have a corresponding biopsy specimen. So for example, in this case, this is kind of similar to our first case. In the background, we do see some mucin. So in the liquid-based cytology, if you see a little bit mucin, which means there is a lot of mucin, and when you see something like this is less likely to be contaminated from the mucin in the intestinal tract. And then you see this cluster of cells. The cell actually show kind of small nucleus, but it's really three-dimensional. Additionally, you see these abnormal mucinous differentiation, mucinous like cytoplasmic mucin. So this is kind of abnormal, and you see this is getting a little bit oranginophilic. So this looks like well-differentiated mucinous adenocarcinoma. If this is the only gland, that we will be really difficult to make a definite diagnosis. So unfortunately, the specimen only have very, very scant cells. So again, these cluster you can see these are abnormal mucinous differentiation and with three-dimensional architecture. So this suggests that it's likely a well-differentiated mucinous adenocarcinoma. So we do have a corresponding core needle biopsy. Again, you see extracellular mucin. It's more than usual. I refer the case to Dr. Gao because he got the biopsy. I want to call this adeno, but this is very well differentiated. So I just need to confirm if he had the same finding in the biopsy, and he does. So we will call the specimen as adenocarcinoma. So in this cluster, despite like a relatively small size of the nucleus, you can tell that the long axes of each nucleus are crossing with each other, which suggests this is disorganization, in contrast to the well organization that we see in a honeycombing cluster. So these that we call drunken honeycombing, because you can tell that the distance between nucleus, some is very close, even overlap, some is very apart, and with very irregular spaces between these nucleus. These are called drunken honeycombing, and which is also a sign suggests that this is a well-differentiated adenocarcinoma. Okay, so this is relatively challenging, but we can still have a very high suspicion that this is adenocarcinoma. Yeah. So with the confirmation in the biopsy, we are going to call this adenocarcinoma. So the next specimen is from a 25-year-old male in the pelvic bone. So again, the patient is young, so which is very, very unusual. The patient actually has multiple bone osteolytic bone lesion. So the clinician suspect that it is metastasis, but the patient is very, very, very young. Kind of unusual. So in the bone biopsy specimen, usually we will only see the hematopoietic component. We won't see these cellular cluster. So in this specimen, we do see like a cohesive cluster with prominent like a polymorphism. Some of the cells actually show very prominent nucleoli. So here we have some single cells, but with very, very prominent nucleolus. So in the biopsy specimen, Dr. Zhang received the biopsy specimen, and she made a very good guess that she thinks these are metastatic FH deficient renal cell carcinoma. The patient doesn't have any image study, but she's standing and it is compatible with FH deficient renal cell carcinoma. So in this very young patient, it is very likely that this is syndromic. The patient might have FH deficient syndrome and develop a very early renal cell carcinoma. And this is a very aggressive type of renal cell carcinoma. And in my experience, around half of the cases, the initial presentation will be metastatic in the bone. So yeah, so this is a relatively unusual case. We have very, very scant cells here, but yeah, they already make the diagnosis in the biopsy. So the clinician need to check if there is any kidney tumor, but we highly suspect there should be one. Okay, let's move to the thyroid specimen. So this is from a 66-year-old male, and the clinical impression is multinodular goiter, but he still receive fine needle aspiration. So on low power, we do see some like background material, but very, very scant. And we see very, very cellular like material. It is very unusual to see these type of very three-dimensional but papillary growth fragment in thyroid specimen. Particularly, there is no nuclear feature of PTC. So the cell all looks very uniform, but arranged in these very large sheets and with like a three-dimensional papillary feature. Additionally, this cluster does has transgressing capillary, so you can see the papillary goes through the cluster, right? So these morphological features are very typical for parathyroid lesion. So the parathyroid lesion, again, in the background, usually is very clean. You won't see like colloid because it's not a thyroid, and you will see very cohesive three-dimensional fragment, and oftentimes with papillary architecture. And it is very common that you can see the capillary meshwork. The cell can look like follicular cell because they are just similar endocrine cells, very small, very uniform, with very condensed chromatin. But because of there is no background colloid and there's no nuclear feature of PTC, this is highly suggestive that this is a parathyroid lesion instead of a thyroid nodule. So when we see something like this, the first thing that we would do is to go to the history to see if the patient is under hemodialysis. So the patient indeed is under hemodialysis. So these represent the secondary parathyroid hyperplasia, clinically mimicking a thyroid nodule. So for these type of specimen, usually we would do a cytospin preparation, and we would do a GATA3 scan to confirm that it is not follicular cell. These are parathyroid cells. So the next specimen, this is what we see most often. In the background, we do see some colloid, but these colloid are very dense. These are not the thin colloid that we usually see. Somebody described these as bubblegum colloid. It looks like a bubble gums. 等我10分钟，对，10分钟，10分钟，谢谢，10分钟。So somebody called this bubblegum colloid. So it looks like a bubble gum and you stick it on the wall. Okay. And on low power, we see some monolayer sheets as well as some abortive type of or decapitated type of papillary front, as well as multinucleated giant cells. So these are multinucleated giant cells. This is often associated with papillary thyroid carcinoma. These are monolayer sheets. And we can start to appreciate this is a very vague pseudo inclusion. There should be pseudo inclusion somewhere. These are skeletal muscle. Ouch. So usually the patient will feel very painful when we see a lot of skeletal muscle in our specimen. And I want to show the decapitated papillary front looks a little bit like this. So it formed like a luminal border around three like a corner, but at the one corner it is like a totally like a blunted. So that looks like a abortive or decapitated papilla. And this is a monolayer sheet. So again, you can see the cell show elongation and with long axis close with each other, so disorganization. So unlike the usual like very round, very uniform honeycombing fragment, these are disorganized and abnormal. Here you can see also a very vague pseudo inclusion over here. I want to find a very good pseudo inclusion, but it's not easy now. Yeah, possibly here? No. Yeah, so sometimes it's not very easy. It takes time. But this is a papillary salivary carcinoma. Direct smear is not very cellular. Okay. The next specimen is a breast aspiration specimen. We rarely receive breast aspiration nowadays because most of the clinicians like the core needle biopsy because they need information for ERPR and HER2. So for this breast aspiration specimen, the first thing that we notice that it is very cellular. The second thing that we notice that it has both large fragment as well as a lot of single cells in the background. So if it is an invasive ductal carcinoma or lobular carcinoma, it is very common that you will see single cell in the background. And in this specimen, we also do not see any myoepithelial cells in the background. So this is compatible with invasive ductal carcinoma. So for the ductal carcinoma, it's quite common that you will have a very polygonal, even angulated shade, looks a little bit like squamous cells. So the ductal carcinoma has a squamoid feature, which is also common and do not just recognize these as a squamous cell carcinoma. So this is typical, very typical for invasive ductal carcinoma. We have a couple pap smear, but it's getting late, so maybe we would just show the most important cases. This is from a 76-year-old female, so very, very old. She has postmenopausal bleeding, apparently. So in this specimen, it is not very cellular, and we see a lot of old blood, and this is concerning. So not very cellular, a lot of degenerative debris and old blood in the background. And we start to see some highly atypical cells with polymorphism. And you can see these very strange looking cells with elongated nucleus. So when we see something like these, like a gigantic cells with very, very atypical like morphological feature, this is a binucleated cells. This looks like a carcinoma. But in the background, we do see some sarcomatous cellular component. So I would say the case is highly suspected to be a triple MT. Okay, so we do see carcinoma cluster, but we also see these very irregular, highly typical gigantic cells and with elongated nucleus. So if we see something like this, we need to think about if there is sarcomatous component. So this case is highly suspected to have a MT. So we will wait for the clinician to do the surgery for the confirmation. Okay, that's it for today.